her CV runs so long, and if one is trying to download it from the website, it is going to run into several pages. So I'm trying to see how much to synthesize all her accolades. She's been the recipient of more than 30 international and national awards, including the 2024 Eminent Woman Scientist for Academic Contribution in the field of medicine for National Academy of Medical Sciences, India, among the women in medicine, and also for the American Academy of Neurology, Baker Teacher Program Award, Global Association of Physicians of Indian Origin, and she has been a distinguished clinician and member in many consortia. I don't know which one to prioritize, but in 2024, the INSAR Cultural Diversity Award, National Senior Women Bioscientist Award, instituted by Janaki Ammal. And she's been from 21 to 22, also received the National Award for Outstanding Efforts in Science and Technology Communication. DST, and she's also received the Sheila Wallace Award, and she's the first Indian recipient. This is a very prestigious award, and this is instituted by the ICNA 2014 Fellowship Award by Faculty of Medicine, McGill University. So going back, of course, there are even a lot of awards, but I think everybody is anxious to listen to Sheffali's talk on epilepsy and cerebral palsy. I did not go into the introduction of the topic of the day long because I would like to hear her cover, and if there are any other inputs to be added after her talk is over, I'll also give some additional comments and inputs at that time. Thank you. Over to you, Sheffali. It's been a pleasure to actually introduce you. Thank you.
Thank you. Thank you, ma'am. Thank you very much for your kind introduction. I'm really grateful to Mallikarjun sir and Asha for having me over, and very honored to be introduced by you. Can I enable my sharing the screen? You can stop sharing the screen. The host.
Mallikarjun sir, please stop sharing.
Thanks.
Yeah, thank you. Go ahead.
Can I be allowed to share the screen, sir? I'm host is disabled to point.
Sir, make ma'am co-host.
Yeah, I'm making. But I don't know, something is wrong. I'm unable to make her. Yes.
Sir, वो आगे जो बन गया. Thank you. Yeah. So not okay. Can you see my full screen? Sir, can you see my full screen?
Yes, Sheffali, we can, Sheffali.
Okay. Thank you. And thank you very much. Good evening to all. Talking about epilepsy in childhood, cerebral palsy, and as Sunanda ma'am has said, it is a very tricky situation, and one has to be clear how it is going to take on. I have nothing to disclose, and I dedicate to all my presentations to children with special needs and their families. And yes, 6th October being the World Cerebral Palsy Day, and it will be uniquely CPA trying to give importance. And we have to think about the various things these children can do. The capability approach has to be kept in mind, not the medical model. And it is very important to have humanism in our active, and destigmatization, which are very much lacking in India, and I need to start talking at the onset about humanism and destigmatization. So the flow of my presentation would be introduction, the epidemiology, the etiopathogenesis, the risk factors, associations of epilepsy with various types of CP, various types of seizures which can be seen, the EEG findings, the outcomes and prognosis, and an overview on the management. As we all know, obviously all of us know know that CP refers to a heterogeneous group of conditions involving the permanent motor dysfunction that affects the muscle tone, posture, and movement, and a frequency of around 2 to 2.5 per thousand births have been there, and motor function abnormalities being the core of cerebral palsy. But you have multi-system involvement, so you need to have a holistic evaluation of a child with the problem of sensation, perception, cognition, communication, behavioral disorders, secondary musculoskeletal disorders, and epilepsy too. So this was the INCLIN study Sunanda ma'am was mentioning too, in which I was the network coordinator. Dr. Arora was the team leader, and MKC Nair sir was the PI. And we had found that, about 12% of children in between the age group of 2 to 9 years had one or more neurodevelopmental disorders. And this is will be a simple figure to see and remember in this one. The 12% overall between 2 to 9 years having one or more neurodevelopmental disorders, and 21.8% had comorbidities. Something important, because we have to understand that most of these conditions will have host of other issues to be seen. So that is why a cerebral palsy can have other problems, and epilepsy, cognitive impairment are some of them. And this year, the data which we had collected was in the year of 2011. And that year we had census of India. And in the census, the age group of 2 to 9 years, there were 173 million children. So the extrapolated version of 12% came up to be 23.7 million children. So that was one thing. And the neuromotor impairment, including cerebral palsy, what happened was we had coined the term neuromotor impairment for the for the logistics, because a child is going to come to a primary care provider, primary care physician, point of care provider, health provider would be coming with a motor problem. It will not come with a CP, or it could be CP, it could be neuromuscular disorder, it could be post-stroke, post-meningoencephalitic sequelae, etc., etc. So all of them were clubbed under one NMI. So in the NMI, the neuromotor impairment, which included CP, the overall prevalence, estimated numbers in millions in the age group of 2 to 9 years was 3.1 million. So it was ranging from 2.1 to 4, but it was 3.1 million. So this 3.1 million was the projected thing. And out of the NDDs, out of the 62 cases which had been identified of this NMI, out of these 62, the 46.8% had CP, spastic CB, and 22.6% had neuromuscular disorders, and 30.6% had other neuromotor impairments. And in that, we found that, IED was seen in 144, and which was there. And among children with NDD, the NMICP, which was 74.2%, was the commonest, followed by IED, which was 56.9%, and epilepsy, which was 55.9%. And they frequently had coexisting entities, which we had seen in the previous slide, that 21.8% had comorbidities. So this was the INCLIN tool, initial one, which we had made for 2 to 9 years for neuromotor impairments, and it had a good sensitivity of and a good specificity, and we could pick up. But we found out that, when we did the study, that we could not pick up most of the dyskinetic CPs and with comorbidity. So then we had, and this was also for the age group 2 to 9 years, because the study was between 2 to 9 years. So then we carried out AIIMS modified INCLIN tool, which was now the age range was broadened from 1 month to 18 years. And also for the dyskinetic CPs and all what were getting missed initially were added. The questions and observations were added, and then we found and did the validation, which has been very good, and very good psychometrics, and is published in Frontiers in Public Health. All these, INCLIN tools there were 4 INCLIN tools which were made of autism, epilepsy, neuromotor impairment, and ADHD. We had modified all of them for expanding the age grade. And initially, they were all autism and ADHD were DSM-4 TR based, because that time it was DSM-4 TR. Then they were modified to DSM-5. So we have a PED NeuroAIMS diagnostic app, which has autism from 1 to 14 years, ADHD 6 to 18 years, both from DSM-5 TR, DSM-5 based, and which is in consonance with ICD-11. 11. The old incline tools were based basically on, DSM-4-TR. This is DSM-5. Then epilepsy as from 1 month to 18 years and neuromotor impairments 1 month to 18 years. So this is one app which is there and it is on our website, www.peidneuroaims.org. So then, this cerebral palsy and developmental delay, then this was a paper in which, Bola had led this paper in which we tried to understand the available evidence of the global and regional prevalence of CP and developmental ID. So it was seen in this that globally 8.1 million or 1.2% children under 5 years were estimated to have CP and 16.1 million or 2.4 had IDs. And over 98% of them, ID and CP resided in LMICs. So CP and IDs accounted for 6.5 and 4.5% of aggregate, years lived with disabilities in these regions. So you see all this red and all that dark areas are in our areas for both of the CP and ID. And we all know the topographical and physiological classification of CP, and we also know the early markers of, having from poor feeding and swallowing difficulties to abnormal general movements. We are also currently carrying out a study in which we are trying to see the home-based videos and the hospital videos of general movements and trying to see whether we can predict CP. We are doing with CP and autism both. So that is there. We all know about fist in hands and all that. And the scope, it's beyond the scope, but I would just to create the stage, set the stage I was talking about. So we can also, we can suspect earlier, with all this twisted hands and, otherwise scissoring of legs and the increased spasticity and all that, besides delayed in milestones and of slow walking if they are walking. And cognitive impairment can be there. And now coming to epilepsy and CP. So overall incidence of epilepsy in general population is 3 to 6 per 1,000. And cortical pathologies predispose for children epilepsy and CP. And CP often coexists with epilepsy, which is drug refractory in majority of the cases. Epilepsy has been shown to be in 25 to 45% of individuals CP, and CP is also a risk factor for status epilepticus and for it to be drug refractory. So this was another study in which we were trying to, this was a study at the systematic review which has been done. It was trying to, it is trying to see the prognostic messages from the systematic review of CP. And in this, it was found that 1 in 4 children with cerebral palsy have epilepsy. And epilepsy was commonest in the spastic CP with 50 to 94% of them having. And in 71% of epilepsy with CP, it was associated intellectual disability as well. Yeah. So it was also seen that, in this another systematic review and meta-analysis, that total prevalence was 38% in overall CP. And this was of a meta-analysis of 72 articles with 53,969 children with CP. They found the total overall prevalence being 38%. And the prevalence of epilepsy was 46.4% in the clinical sample-based studies and in 31.6% in population-based studies. Obviously, those patients who are coming to the hospitals or the clinics setting are going to be having more problems and comorbidities. This is the prevalence of epilepsy and CP in different countries or regions in the population-based study. Then the epilepsy in children with cerebral palsy, a data linkage study, they have seen the prevalence was 42% in a CP registry, and it was 43.2% in CP administrative data and 1.3% in controls. And they found that high GMFCS levels increased risk for epilepsy. CP with epilepsy had increased number and length of hospital stay and emergency visits than with children with just CP or just epilepsy. In another study, they found that the quadriparetic CP, which is understandably going to be the most common type of CP to have epilepsy, and cases with CP had higher association with early seizure onset, probably neonatal seizures, global developmental delay, abnormal imaging. They may require more than one anti-seizure medication as compared to those without CP. And majority of the seizures were focal because of focal, structural damage which was taking place. Also, the prolonged courses of anti-seizure medications, more anti-seizure medications use, polytherapy, and higher incidence of drug refractory seizures and admissions for status was reported in those children of epilepsy with CP. But mind you, there may be some mimickers for epilepsy like breath-holding spells, reflex anoxic seizures, or vasovagal syncope, or paroxysmal movement disorders, dyskinesia, stereotypic movements. So it's important that you have a video recording of events, and video EEG may be important, but video recording of the events is the most important. And because most of the people have smartphones now, so it becomes easy. So we tell any movement happening, you please record, because you just have to put the mobile. Now, when is the onset of epilepsy? The onset of seizure is typically during the first 2 years of life, but can occur at any age. Those who are having quadriplegic CPs have an earlier onset of epilepsy. Those with hemiplegic CPs may have a delayed onset of epilepsy. So you can see that, if you're having a hemiplegia, you may have a later onset, and those with having all 4 limbs involved, you may have an earlier onset of seizure. Now, what are the genetic, prenatal, perinatal, and postnatal events which predispose to epilepsy? The inadequate oxygenation in early life leads to structural abnormalities in the maturational stage of the brain development, causing encephaloplasia, causing PVL, causing atrophy. There may be associated infections and chromosomal anomalies. There may be malformations like agenesis of corpus callosum, cortical dysplasias like lissencephaly, unilateral megalencephaly, and neuron hypertrophias. A low APGAR score at birth, a positive imaging finding, severe impairment and severe IT and spastic CP, and the family history and early onset of seizures are common predisposing factors. Seizures take place when there is overactivity or a misdirected activity of electrical circuits in the brain. So during early life, an inadequate oxygenation, which takes place in cases of birth asphyxias, can lead to structural cerebral abnormalities, which relate to the maturation stage of the brain at the time of the insult. So perinatally acquired lesions can cause encephalomalacia, periventricular locomalacia, or diffuse atrophy. That's why, you can, if you have any focal areas coming, so you have a lot of focal epilepsies also. Other less common potential causes of epilepsy in CP include pre and perinatal infections and chromosomal anomalies. Postnatal could be head trauma, and having a head trauma, severe intracranial infections, hypoxic injury, stroke, etc. In hemiplegic seizure, if the lesion is acquired postnatally, the risk of epilepsy increases. And epilepsy can be an estimation of the severity of the neurological damage, which has taken place and the cortical injury. And it might be an earlier sign, in cases of sometimes hemiparesis, you may have a seizure which may have come first, may have been noticed first. So if you have neonatal seizures, family history of epilepsies, you have EEG abnormalities, cranial imaging abnormalities, severe IT, quadriplegia, low APGAR scores, prematurity, all of them are supposed to be risk factors. So this was a single center study in which they found in 268 patients with CP. They followed up, for up to 2 years, and they were widespread range, and 36.9% had epilepsy and 10.8% had drug refractory. Asphyxia was seen in about 1/3. Hemorrhagic infarction and brain infection were also associated with epilepsy, and brain infection was seen in 1/4. History of asphyxia, febrile seizures, neonatal seizures, spastic quadriplegia, and more severely impaired gross motor function and IT were found to be risk factors for epilepsy. So, they have studied between prematurity along with low birth weight, the asphyxia and brain injury in quadriplegia, diplegia, and hemiplegia with and without epilepsy, and seen the various causalities. In another study of 234 children, the patients were divided into 2 groups with or without epilepsy. And they found the risk factors of neonatal seizures, focal clonic or generalized tonic neonatal seizures, abnormal baseline rhythm on neonatal encephalography, discharge from NICU on at least 1 anti-seizure medication, quadriplegic form of CP, or epileptic activity on 6-month EEG, or an abnormal cranial MRI, or a cognitive impairment, microcephaly, and visual problems. In another study trying to understand the risk factors, they had retrospectively analyzed 181 children with CP between 4 to 17 years, and they found the incidence of epilepsy in CP was 56.3%, and 43% had drug-refractory epilepsy. And they found maternal hypertension was an important risk factor prenatally, and intrapartum they found delivery by cesarean section was seen to be correlating, and postnatally they found neonatal convulsions to have a risk. In another study, they were trying to see a CP co-occurring autism spectrum disorder, motor functioning. They found ASD among children with CP overall 6.9%, and frequency of autism was higher among children with non-spastic CP and particularly hypotonic CP in 18.4%. The frequency of co-occurring epilepsy was 41.5 and did not get affected by the ASD status or the CB subtype. So frequency was epilepsy was higher in children with limited or no walking ability. So obviously they must have a severe damage to the brain. As mentioned earlier, the neurobehavioral seizures risk of developing epilepsy in CP is significantly increased with the occurrence of neurobehavioral seizures up to 42%. And 90% of children with dyskinetic CP, 45% of tetraplegic, 29% of diaplegic, and 16% of hemiplegic have had neonatal seizures. The younger the age at seizure onset, particularly during the neonatal period, is associated with drug refractoriness. Neonatal seizures are associated with a higher prevalence and a poor prognosis of epilepsy and CP. Although the immature brain seems less vulnerable to neuronal damage caused by seizures, it has been suggested that neonatal seizures may leave regions of neurons prone to epileptogenesis later in life. And they found that quadriplegic CP had 42.6%, and then followed by mixed and then hemiplegic CPs to have cerebral palsy. Have epilepsy in cerebral palsy. So basically, quadriplegic and mixed had the most majority of them. And in children with epilepsy, the degree of GMFS scale was most often between 5 or 2, which is 49% and 31% respectively. In another study, which they are trying to see the distribution of impairments among children with cerebral palsy in a large cohort of Australian patients, in which they had patients of 3,466, they found that the proportion of each associated impairment increased with increasing GMFCS, and epilepsy was most prevalent in persons with spastic quadriplegia, 53%, and least with spastic diaplegia, 14%, which was understandable. So seizures are most common in those with spastic quadriplegias and hemiplegic subtypes, and less common in the mild symmetric spastic diaplegia and ethetoid subtypes. Now, other thing is ID. Intellectual disability is more common people with CP who have seizures than those who don't have seizures. Severe ID is more likely in those with multiple seizures. Epilepsy per se can impose an additional cognitive burden. Why? Because if it is difficult to control, the anti-seizure medications which causes sedation may impair learning and socialization, and perhaps more it's because of its side effects too. In a study, they show that children with epilepsy were more deeply disabled in the intellectual levels, 44% versus 6% in the group without epilepsy. Another thing, they found that cognitive profile was trying to seen in a complete national cohort of children with CP and its associated comorbidities, and they had a group of preschool CP children between 4 to 6 years from Iceland. They found that epilepsy was the only factor which influenced the level of intellectual development, and 60% of the children had an IQ or DQ more than 7. And they found that median scores on the Wechsler's preschool and primary school of scale of intelligence were, the full scale IQ was 84, verbal 92, and performance 77. So see, performance is coming less. Children with diaplegia and quadriplegia had a significantly lower performance IQ than the verbal IQ. So, and it is important to see that the cognitive skills can be masked by limitations of movement and motor control in children with CP. So one has to be very careful when we are assessing them when doing their evaluation for the cognition. Concomitant epilepsy was seen to be associated with higher frequency of ID. There was incidence of epilepsy had a negative correlation with level of intellectual development. Children with cognitive impairment had a higher frequency of epilepsy than those without cognitive impairment. And 68% of patients with epilepsy as a comorbidity had severe intellectual development. Now, coming to DRE, drug refractory epilepsy, it's important to understand what is causing the drug refractoriness. Poor seizure control causes a significant medical and psychosocial burden with vast implications, including an increased mortality risk. The drug-resistant epilepsy may be more disabling than the musculoskeletal components of the CP itself. 43% of cases have been reported to be DRE. The highest incidence has been found in mixed type of CP and tetraplegic and even the extrapyramidal form has been shown to be having to 80%. So hemiplegic has been the least. So in this study, they were trying to understand the clinical risk factors that could predict the DRE in children with CP. And they found that a low ABGAS score, a younger age at seizure onset, occurrence of seizure in the neonatal period, a focal onset epilepsy, a focal slowing on the EEG, and a status epilepticus as the first seizure were, all risk factors for drug refractoriness. And when they saw the area under the curve, they found that 4 independent risk factors was a low ABGAS score at 5 minutes, neonatal seizure, focal onset of epilepsy, and focal slowing per EEG. Factors that had occurred in a significantly higher frequency in drug refractory ones, epilepsy group for intellectual disability, attendance of a special education system, larger number of failed anti-seizure medications, adherence to a ketogenic diet, undergone a vagal nerve, and epilepsy surgery. So all these drug refractory and treatment thereof were seen more in those, drug refractory ones. Now, coming to what are the seizure types? Due to a focal brain injury, you may have focal seizures are the most common seizure type in children with CP. At times, these seizures may develop secondary generalization. All children with hemiplegic CP tend to have partial seizures, but you may have Lennox-Gastaut syndrome in up to 18%. So you may actually, if you see, you may have infantile spasm, you may have generalized only, you may have partial and several types of generalized and partial and generalized tonic-clonic or only partial. And that there are many types can be there and many combinations can be there. Epilepsy syndromes in CP can be very varied and, evolving and mostly self-limiting. Of the, 256 children they had studied, in the study, they found that 36% had one or more febrile or febrile seizures beyond the neonatal period, and 34% had epilepsy. And they found that neonatal seizures, spastic quadriplegic CP, GMFCS of 4 and 5 were risk factors for epilepsy. And they also found that 60% had electrographic evidence of a self-limited focal epilepsy. 12.6% had infantile spasms and 3% had LGS. Trigger-triggered seizures were seen in 10% and genetic generalized epilepsy in 2%. So they found that in this study, 75% of self-limited focal epilepsy variant on EEG had no seizures more than 2 years beyond therapy, so they had a good outcome. And self-limited focal epilepsy variants can occur more commonly in CP. So besides those catastrophic, now words are not used at catastrophic words, and benign and catastrophe are not used now in ILA. So the difficult to treat drug refractory ones are there, but on the other side, you may also have lots of self-limited focal epilepsy variants as well. And they have they can be because of the vascular injury which has taken place, and the peak years of seizures were between 3 to 12 years, and 70% having seizures during this age range, and only 9% had seizures after 13 years. So they were, self-limited. And they've also shown that there was an overlapping clinical and EEG features which could be seen in the self-limiting focal epilepsy that was similar to those which are seen in self-limiting focal epilepsy of typically developing children as well. Now coming to EEG, the problem is that what is happening with the EEG discharges? EEG may have, they studied in 151 children in this study, in which 70 did not have clinical seizures, but only 34.3 had normal EEG tracing. So they had, abnormal discharges there in the EEG, otherwise, even without having seizures. EEG findings were generalized and asynchronous slow waves in 40%, generalized epileptiform with discharges in 32.9%, and focal and multifocal abnormalities 5.8%. More than 80% of CP with epilepsy had abnormal EEG with more focal and generalized epileptiform activity. And 43% of those with hemiplegic had focal discharges, although clinically they can have have a quick spread, so might be seen as generalized. And majority of children with quadriplegia and diaplegia also showed generalized. So focal slowing and focal multiform epileptiform discharges were more risk for having a refractory. Focal and multifocal discharges as well as focal slowing were all associated with drug refractory epilepsy, and the focal slowing may suggest a destructive focal white matter lesion caused by a traumatic, congenital, vascular, or infectious process that may lead to an epileptogenic lesion and eventually to cerebral impairment. The EEG abnormalities have been linked to cognitive and behavioral impairment in children in general and in children with cerebral palsy. So just this was not done in CP children, but I just wanted you to see that there was a comparison in the study which is carried out in our institute, that idiopathic generalized epilepsy and between self-limiting focal epilepsies, they found that the WIS scores and the proportion of the impairment was comparable between the self-limited focal as well as the generalized epilepsy. So it was also noticed on DTI, they were both the generalized as well as the self-limited focal showed significant correlation of the cognition and executive function and fractional anisotropy of white matter in cingulate cortex and corpus callosum. So you have to see that these are the typically developing children we're talking about. So cognition and executive function showed a negative correlation with the power of the slowing of the rhythms. So what I meant was that when you are having these self-limiting conditions, even in the typically developing, causing cognitive issues. So that is why we have to keep in mind that it would be in cerebral palsy that is going to also factor is going to be there. These all abnormalities can have autistic traits, can cause selective cognitive impairments, frontal lobe dysfunction, and lots of other issues can take place. But one has to just keep in mind that many times when you're having a recent onset behavioral problem in these children with CP, we should do a sleep and wake cycle. Both the sleep study and the awake study of EEG. And you may have, if you have a more abnormality, there's a sleep potentiated intraictal epileptiform discharges have been associated with something which was called ESAS earlier, and now it is called ESWAS, in which you need to give sometimes immunotherapy and benzodiazepines works. So if you're having recent onset behavior issues or a neurocognitive decline in these children, then you should have a sleep as well as an awake age. What does epilepsy cause? It causes pseudo-regression of milestones, and an ambulant child, it can lead to trauma, particularly and even the myoclonic jerks can cause problems. Non-ambulant child can suffer gradual loss of posture, and difficult to control seizures can lead to cognitive decline and subclinical persisting seizures. Hemiplegic CP with epilepsy had lesser IQ scores compared with the non-epileptic hemiplegic CP. This was a group of, they followed 28 cases of unchanging CP versus 37 with worsening CP, and they found that daily or weekly seizure frequencies were more in the worsening CP group. They also saw that the intense seizure activity induces the network disruption, leading to motor disability. So the seizures can also worsen the motor disabilities. This is what I wanted to add. Outcome of epilepsy in CP, it is to be seen that there are two groups. Group A is CP due to white matter changes, damage or unknown etiology. Group B is due to CNS malformation, CNS infection, and gray matter damage. So group A is the one here and group B is the one there. So children with CP caused by CNS malformation, CNS infection, and gray matter damage all showed a higher frequency of epilepsy than those children with of any other etiology, and they had a lesser chance of becoming seizure-free. After a duration of 2 years, a good seizure outcome was estimated in 33% in group A versus only 7% in group B. So somebody having a CNS malformation or an infection or a gray matter damage had a poorer outcome. And individuals with spastic hemiplegic CP have a higher relapse rate of epilepsy. With spastic quadriplegia have a lower rate of seizure control. Those with spastic diaplegia are more likely to be seizure-free. They have the mildest. The impact of GMFS score on epilepsy prognosis appears to be insignificant in this current study, which is being quoting. This could be explained by the fact that GMFS is a score that reflects the motor dysfunction as a result of white matter enzymes. Then the seizure outcomes, you see that this was trying to see the seizure outcomes in which the retrospective cohort of 107 cerebral palsy patients with epilepsy followed for up to 8 years. They found the sustained freedom from seizures before 6 months of treatment was in 6.5%, delayed but sustained seizure freedom in 27.1%. But the most common was the relapsing and remitting course in 43.9%, that means around 50%. And seizure freedom was never attained in 22.4%. So 30%, that means 1/3 of epilepsy cases are likely to become inactive over time, they may be controlled. 23% remain seizure-free at least 2 years of stopping ASM, but 1/3 can persist to have persistent intractable seizures, and they also have increased risk of sudden death, SUDEP and status epilepticus. You need to have a seizure action plan, patient and caregiver education, abortive education, compliance to medications, and monitoring of side effects and interaction. So basically, for generalized, you give valproate, and you may add on clobazam. For less than 6 months, you give phenobarb. So basically, generally, we give phenobarb for neonatal seizures. In focal, you give carbamazepine or oxcarbazepine. You may give valproate as well. And for comorbidities, if you have to see if you have sleep onset latency, we like to actually give melatonin. If you are having behavioral problems and all that, you may like to add either clonidine, or you may also, sometimes you may add risperidone. For dystonias, yes, triaxiphenidil or levodopa. And for spasticity, baclofen, tizanidine. And for breath holding spells, you do give iron and paracetam. And if they are refractory cases, then you may try other drugs, like topiramate and clobazam. And otherwise, you need to try various ketogenic diet therapies and may consider some surgeries or vagal nerve stimulation. And we are also doing transcranial magnetic stimulation here. So basically, the ASMs lead to seizure freedom in 70% of children. And 3 factors which are important for the choice is seizure type, efficacy of drug for seizure type, and side effect. So for epileptic spasm, we give steroids, vigabatrin, and you may give ACTH or high-dose misolone. For focal seizures, many new treatments, many new drugs have come, oxcarbazepine and carbazepine and all. And generalized epilepsies, valproic acid remains the most effective drug. And we have to understand that, a carefully selected medical therapy guided by seizure type and AAT characteristics is more effective and is very effective to control in 2/3 of patients. After 2 years or more of seizure freedom, if the recurrence risk after AAT withdrawal is acceptable, slow weaning is done over a period of 6 weeks or longer. And after discontinuation, 70% remain seizure-free. And of those which have the recurrence, the majority achieve seizure control on restarting of them. So when the treatment with 2 or more anti-seizure medications fails, then we consider we first think of dietary therapies. And if you have a surgical, it's a surgical candidate, you may need epilepsy surgery, maybe for lesional, or maybe like you have excessive drop attacks and all, you may like to have palliative chelostomy. VNS can be done, but we are more often doing transcranial magnetic stimulation at our center. And for West syndrome, I mentioned to you, yes, and focal seizures and all that is there. New drugs which have come up on the horizon are perampanel and sometimes bevacetam, and obviously cannabidiol has also come up. I want to end by making 1 or 2 points. Baclofen has been used for antispasticity, but I want you to know that it has been shown to lower the seizure threshold. So that is to be kept in mind. So tizanidine has to be preferred. All the use of spasticity medications and other debate. Clonazepam is a very potent benzodiazepine and is pretty useful. Its issues are it can significantly causes risk of respiratory depression. It causes a lot of hypersalivation. So all of them are already having sinuria and all, and drooling is there. They may have a lot of problems. And it may also impair judgment, thinking, and motor skills. You need to have a social support and parental counseling, very, very important. And the total handholding for the family is very important. And we have a lot of patient information material for all these patients in Hindi and English, and domestic management of seizures, and also videos for the same on our website, and a seizure diary and a seizure card for children who are going to schools, so that you can give the abortive medication which have to be given. Midacid nasal spray has to be can be given, and has given to them. We tell them to keep one in the bag all the time and one at home. So a lot of patient information material on various exercises with development, stimulation, beginning, structures, teaching exercises. You have modified constant induced movement therapies and all of them are available. And we had done also virtual reality assistive constant induced movement therapy, which was very helpful, and also a TMS along with the constant induced movement therapy, which has been helpful and did not increase seizures in these patients. This I've already shown to you. I'm just ending up by saying that still the knowledge, attitude, practice, the knowledge amongst even the paramedics at AIIMS was poor when we just try to study on them for having various knowledge about neurodevelopmental disorders. So we are a very long shot away. We're doing a DST study to try to develop a module and try to teach them. And it's also important to pick up these children early. So making one algorithm for a primary, secondary, and tertiary healthcare center setting for the WHO, and we have made certain video packages for those who have high risk newborns will get the early intervention, and those who are not risk, then they get the nurturing care framework. And if those who are having markers to go towards CP, they have separate videos for stimulation and all. So also have this Holding Hands in Magical Years, a collaboration with the Hans Foundation, trying to provide developmental services holistically under one roof. This is very important to see that this paper, which was written, we wanted to specify that the NCF, the Nurturing Care Framework, has to support the child's care and development in first years of life across 5 dimensions: responsive caregiving, early learning, safety and security, nutrition and health. But it has to be modified for people from LMICs. So for finally, the take-home messages would be: epilepsy is an index of severity of cerebral palsy. Brain damage is usually more severe when the epilepsy occurs. CP associated with epilepsy is also far more frequently accompanied by with intellectual disability, and the level of physical disability associated with CP does not predetermine to a child's happiness and quality of life. But yes, the seizures can cause a problem in the motor function, and we are going to look for equity. Being challenged in life is inevitable, but being defeated is optional. And when the world says give up, hope whispers, try it one more time. This is my team and AIIMS looking at different brightness today and on a foundation day and the World Autism Day. And thank you so much. And I invite you to the 17th Asian Child Neurology Congress next year, New Delhi, from 16th to 20th September, and the registrations are on. Thank you so much for your patience. I'll be happy to answer any queries.
Thank you, madam.
Thank you. Thank you for that extensive presentation, Dr. Sheffali. And I think you practically covered the entire gamut, starting from the risk factors, the etiopathogenesis, the outcomes. And I think the management, of course, you did define the various conditions in which management has to be modified. And also, I think there have been a lot of questions. Perhaps we can again do the concluding remarks later after answering the questions, because I'm sure there are quite a few questions which have come about.
Ma'am, there is a question from Himani. She's asking to shed some light on the role of physiotherapy management of cerebral palsy and epilepsy, how effective it is, and name few strategies which can be incorporated or any contraindications of using VNS in CP patients.
Physiotherapy, yes, there is there is no contraindication, and what normally has to be done is done, except somebody who is having too many flurry of seizures in a day. So we would like the seizures to be a bit under control. That is the only thing, that there should not be too many seizures and impacting that time. So that time, otherwise we should continue. Otherwise it becomes a whole negative cycle, so that can be done. That has to be the only thing, is that that time if somebody's had a status or more flurry of seizures, that is the time which we are going to be there. Yes, VNS does not have any contraindication, but we may not like to give somebody who's severely cognitively impaired in that situation. Otherwise, there's no problem about giving. But we have been trying, and we have been doing transcranial magnetic stimulation, which is basically non-invasive and which is done from the exterior. So we have been doing for focal epilepsies, as well as even for ESES, the one which I told you, that if they are having some cognitive impairment and the behavior thing, you need to have a sleep and awake thing. So in that also we have been doing in research mode, and now we have started doing in service mode after completing. And even for hemiplegic CP, we had done the TMS in which some of them did have epilepsy, and the epilepsy was not aggravated during the TMS, so it can be also given. Anything else?
Yes, ma'am. Yeah, Trupti, go ahead. Yes, ma'am, there is one more question. There is a child who is 13 years old. She has moderate ASD and she is even epileptic child. So Pooja Roy is asking, as a special educator, how to manage a classroom situations, because sometimes it becomes difficult to handle her at classrooms. She bites sometimes.
See, as I mentioned to you, somebody having the behavior thing. So if this child should have a sleep and awake EEG both, because many times what happens, your awake EEG may be practically normal also, and your sleep EEG may be bad. So that is what that sleep potentiation one, and in that you have recent onset behavior issues and cognitive decline, and they get improved by benzodiazepine like clobazam can be used, and we give pulse steroids. So that would be very important to see. And I think it will be important to that I think would be very important to see. If that is subtle, then maybe we may like to give, we may like to give some risperidone or something for the behavior thing, provided that the epileptic part and the EEG discharges are okay in that situation. Because but before that, we should also see for the special educator, it's important that before I start to go and thinking of where. First, obviously, because epilepsy is there, I like to do a sleep and awake EEG, fine. But before going to do the starting her on any risperidone or something, I would like to see whether there are some analyze the behavior, whether there are some trigger to that behavior which is there, or it is always there. Sometimes if it is situational, then we will have to, the drugs will not act, then we will have to try to have we'll need a psychologist to help and guide, and we'll make a plan. Even the special educator can also guide that. We'll have to see what was the trigger and how to decondition the child from that. So the behavior intervention plan would be more important to see. That is also important to keep in mind, not just adding the drug. But yes, because epilepsy was there, I would like to have a sleep as well as awake EEG. Both.
Ma'am, there is one more question. Someone is asking, my son is 7 months old, is having infantile spasm since 3 months of age, and is suspected cerebral palsy. He has failed prednisolone, vigabatrin, and ACTH. What are possible medicine interventions ahead?
Yeah, in that situation, if the appropriate doses things have been this thing, then we can plan a ketogenic diet for the child. The ketogenic diet can be given, and ketogenic they can try for the main ketogenic diet. Because you have various ketogenic diets. You may have ketogenic diet, which is the 4:1, that is there, and otherwise you have modified Atkins and LGIT. So we will like to give the classic ketogenic diet to this patient and try. In addition, going to give other drugs as well. And I would like to also have, but what is the age you said? 6 months, 8 months?
7 months.
7 months. So one also would like to have the EEG to see whether it continues to have hypsarrhythmia, or it started evolving into some other pattern as well. Otherwise, you will have to use a combination of various other anti-seizure medications, which would involve benzodiazepines as well, valproate and benzodiazepines, and you can go on to many more.
Okay, ma'am. There is one more question. Dr. Durga Prasad is asking, can we use sound stimulation as a therapeutic alternative for seizures?
I haven't read about it or used it. I don't know. Sound, how, I don't understand. I have to check. I've never heard about it also still now.
Uh, Hello. Yeah, sound stimulation people have been trying, but so far I don't think there is conclusive evidence that it works.
Ma'am, how does it act? Because I haven't read about it. Like sound stimulation, you mean they are asking for epilepsy or asking for CP epilepsy?
Ma'am, they are asking for seizures specifically.
Ma'am has heard about it. I haven't.
No,
I
I
haven't.
also have only come across it in the alternative systems that people were using as non-pharmacological therapy and adjuvant therapy, but I am not really familiar with how they're doing it. In fact, there are some ultrasonic, methods that are being tried, and I did not actually go through it at leisure. In detail, because somewhere I did not see it as a very logical management, but then maybe we can go over it in the recent literature. I'm also not very familiar with that. Yeah.
One can always explore it, yeah. But I think they should not try it till we have evidence
Yes.
about it.
Yes.
It doesn't look plausible, na, ma'am. I mean, it doesn't look plausible actually.
Yeah, not only that, in fact, we need to see that where is it working and where is it actually applicable, because it's not at all specific to a particular seizure variety or seizures in cerebral palsy. And so I don't think we should really discuss it in detail.
Ma'am,
I
one
think,
thing somebody has written, ma'am, it is actually, yes, music therapy is being tried in many things. I have been, somebody has written, they come across, must be talking about music therapy, because in music therapy is also being said that even for early child development, you started even the high risk newborns in the NICU. So that is there, and that has some role. I have heard about that, yeah, but we have never used that. I've just heard about it for used for high risk follow up of newborns and all, not per se for epilepsy.
yes. Yeah. No,
But yes, it
I
has
don't.
been used.
True. In fact, music therapy has not been used for epilepsy in cerebral palsy,
So
particularly.
it has been used. Music therapies.
Right. So I think there was one more question. Maybe I can request Ankita to see if there are any more questions.
Yeah, ma'am. There are two more questions.
Yes, please go on. Go ahead and.
Yeah. Someone is asking, if children with epilepsy has epilepsy attack in the classroom, then what kind of precaution should we take first?
See, actually, that's why that seizure card I had showed, very briefly. So that has been made, and the seizure diary has been made, in which way do's and do nots, don'ts have to be written. And the video is there on a website, which we showed to our parents, that, there's a parents' corner on the website. What is it that you have to firstly is to position the child, position into a lateral position, so that the child doesn't aspirate, and the child should not, it's a recovery position, it's a lateral position, so that the child is firstly not aspirating, because because of the trachea and the esophagus being anterior posterior, so there's a possibility of aspiration in other positions, so it has to be lateral position. And care should be taken so that the child does not hurt himself or herself from anything from the side. That would be important. And if the seizure does not respond between 2 to 3 minutes, then the intranasal midazolam spray, which the dose is written, which will be actually 0.2 milligram per kg, and each pop for pediatrics is 500 microgram. That number of pops is written on the reverse side of the seizure card, so that those can be instilled into the nostrils alternate. Matlab. So if you have, suppose, a 10 kg child, so 0.2 would be 2 milligrams. That means 4 pops. That means 2 pops in each nostril. Then you need to shake the bottle, and lest 1 or 2 puffs go in the air, because there is a cannula inside the nostril of the tube, which is again.
I think there is some technical glitch.
No, I think so we can't hear her, sir.
Yeah. There is a maybe problem with madam's connection.
Unless she's back. So we can end then.
Yeah.
Question.
So,
There's one more question.
Yeah, there's one more question.
Sorry,
I
I
saw
lost the connection.
Yeah, they
so
are asking
Sheffali is
whether
back.
epilepsy can be included in 21 disabilities for disability certification.
It is already included. It is in the
Right.
chronic
Yeah.
neurological disease
Right.
category.
Question asking how successful is HBOT therapy in containing seizures such as West syndrome? Hello.
Madam is back. Madam is back.
Yeah. There's one more question. How successful is HBOT
No
therapy?
evidence at all.
Hello.
Hello. Yeah.
The-
Yeah. HBOT therapy has no role in epilepsy.
There was also, I think, a question about when somebody misses a medication.
Medication.
Yeah, Ankita
Yes,
could
yes, ma'am.
Okay.
Yeah. So when
Okay.
someone
Okay.
is
If
asking,
somebody
is
somebody
it
misses
necessary to take medicine on given time as prescribed by doctor for epileptic child? And what happens if parents forget to give the medicine that particular time or they give it lately?
Okay, two things. Before forgetting, the child may vomit. If the child vomits the medication within half an hour of giving the medication, then you repeat the same dose of the medication because the gastric emptying time taken is around 30 minutes. Second thing, if you forget giving the medication, give the medication whenever you remember. But you give the next dose at the time when it has to be given. So don't keep changing everything. So you give the missed dose anytime you remember, and the next dose, you may obviously, I expect you would have missed only one dose. Huh? You won't have missed multiple. So anyway, whenever you remember, you give it, and the subsequent dose, you give it at the same time. That is what is suggested. Another very important message I wanted to tell that, you don't give it in anti-seizure medications do not be given in dhakkans and chammachs and all that stuff because it has to be given in milliliters measured in the syringe because the teaspoons are so many. Even in your own house, if you see, there must be 20 types of teaspoons, and all the dhakkans and all the caps are all just these medications have to be given clearly. They also have side effects. You have to monitor the doses. You can't so you should be giving appropriately measured. They are not dhakkans and chammachs.
I think that's a very important practical suggestion. I find that a lot of people do these permutations and combinations of dosages.
Ma'am, one more thing. For all the liquids, they should shake the liquid before use. Many of them are suspensions. Then what happens is if they don't shake, then the top has less medicine and the bottom has more medicine. So he'll throw seizures when it's in the top of the bottle, and when it's the bottom of the bottle, they may go having toxicity, right?
Yes.
And they should not change the brands every time. I'm not saying stick to which brand, but I'm just trying to say that you should stick to one brand because the pharmacokinetics of various brands keep changing. So some drugs which you're taking long, like if my mom's taking antihypertensive, I don't want them to keep changing brands. So the pharmacokinetics may be different. So same thing for anti-seizure medications. Another thing, many times the doctors prescribe. Doctors do a mistake. They prescribe sustained release preparations in a child with cerebral palsy who is not going to swallow the tablet. A sustained release preparation is an is an entry coated preparation. It's going to come slowly, it's going to release. But when you are cutting it, breaking it, and then crushing it and giving the child, so that whole thing is lost. So I think even for practitioners, it's very important to understand that you have to ask whether the child will be able to swallow a tablet. Otherwise, causing all the problems.
And there are also some very simple precautions which perhaps are overlooked, like keeping the medicines in a cool, dark place, and particularly with medicines like Dilantin, when they're exposed to sunlight and when they're not shaken, as you mentioned, we used to find a lot of problems with that until one goes into the history of how they have kept the medicines at home. So these are some small with the issues that we.
One more thing, ma'am. When they have fever, they stop giving the anti-seizure medications. With the fever, the seizure also gets. I mean, the seizure breakthrough seizures also increase for anybody who's having epilepsy. Anybody, not only CP. Anybody having epilepsy, there's a chance of more breakthrough seizures in any fever. So they stop giving anti-seizure medications कि वो कुछ खाया नहीं है तो कुछ देंगे नहीं. So that is also a big problem. I mean, just thought that.
Yeah, no, it is very important. We find status developing in such cases suddenly.
Absolutely.
Yeah. So I think, I don't know, Ankita, how much time have we got that we should be going over all the, because I think there have been an overlap in the questions.
Yes, ma'am. I guess we still have 2-3 more minutes. We can take one more question.
Okay.
So there is a question. If an EEG is without hips arrhythmia after ACTH therapy, but jerks are still present similar to infantile spasms, can it still be treated as per protocols of infantile spasm?
No, there must be something else on the EEG, na? If you're having spasms and you are not having hips arrhythmia, then it must have been evolving to Lennox-Gastaut syndrome, which is going to be more refractory. So your protocols will change according to Lennox-Gastaut syndrome. So I think it is not that. Your the West syndrome is diagnosed by a triad of your infantile spasm, your developmental delay, and your hips arrhythmia on EEG. So you have to have a hips arrhythmia or hips arrhythmia variant on an EEG to diagnose it as Hess syndrome. So he must be having an infantile spasm, but maybe having other seizures. So multiple seizure types are happening. Tonic seizures might have come up. So it might be evolving into Lennox-Gastaut, because after West, it will even become total normal, or you may evolve into a Lennox-Gastaut syndrome. So that is one thing. And somebody said tunic lights. Anybody sometimes, having so much of screen time, watching too much of TV, sleep deprivation, flickering lights, they say that LED goggles may not be like to be done. You may not like to do a VR in a small child who's going to be evolving CP, you may not like that flickering red light of that LED goggles. The goggles VR you may not like because that may precipitate a seizure, and doing a photos, so that is those things they are known to do. I did not understand tunic lights. I don't know what tunic light means, but I'm talking generally about lights. Ma'am, what does tunic light mean? I don't know.
Yeah. No, I also don't know what tunic lights are, but I think definitely the photogenic epilepsy is not so uncommon as people think. And so I think these lights are not really good. So I really have no idea what the tunic lights are, because now there are a lot of alternative therapies coming, and but I think they haven't met the test of time. So we do not usually advocate something which has perhaps only anecdotal in one child. That is the thing.
But flickering lights avoid karna. We should avoid flickering lights in the child.
We should avoid. We should avoid.
Flickering lights.
Yes. We should avoid. In fact, not only in CP, whenever a child has epilepsy, I think we sort of have to be very careful in exposure to a lot of these flickering lights, I guess. Yes, and so with that, if all the questions are over, I must congratulate Sheffali for such an excellent presentation covering a lot of topics, and epilepsy in general and epilepsy in CP in particular is such a vast topic that it is very difficult for you to cover in this time. In fact, I would have suggested a series of two webinars had I known this, and particularly with your experience, I think there's so much you can say. In fact, when you were highlighting the recent studies, it was a real continuing education for me as well. Many of those, for instance, even thinking of, when you're looking at many of these drug-resistant epilepsies and all, we know about many of the things non-pharmacological that are being used, the surgery, the ketogenic diets and all that. They become a subject on their own if we are discussing on a management and all. And I thought for this audience, it may not be needed. So you've really covered all the basic essential stuff. And for I had one question. When you were talking about epilepsy syndromes, you showed actually a summed up study by Monica Cooper, which was talking about mostly self-limiting focal epilepsies. Now, for me, my experience was that many of the focal syndromes as the child grows have not been self-limiting. So can you just explain a little about that?
You do have this, we keep talking about the drug refractory epilepsy.
Mm.
But what I meant was that, sometimes the drug refractory are there, which will be there in 1/3. In the others, when they are there, when you have self-limiting ones, they have mostly self-limiting focal because they had a focal lesion, right? So you have focal. So even in the self-limiting focal one, they are going to have some cognitive and behavioral issues as well. All but they will get remit, and they will be only 7% were there beyond a certain amount of time. Remember, only 7% or so. So most of them are going to remit. So that is what I was meaning, that yes, 1/3 are going to be drug refractory, but you may have the ones, you may have some of them who may be also like the self-limiting ones, which may be there. And then I mentioned a study from our institute where we are doing self-limiting studies were being done. And ma'am, in this, they had also found that, the problems in this Cooper one, the Monica Cooper one were finding they were similar EG findings as they had found in typically developed. So that the self-limiting focal and the self-limiting generalized had some problems on the they had cognitive and executive function poor, and that was correlating on the DTI. So that means there is certain things which we don't even see in typically developing. So in CP, this will also be adding. That's why I correlated that with our study. Our study was not with CP, but with the self-limiting. So in the self-limiting also, we have to not feel ki it's self-limited, so it's okay. It may be causing some cognitive and executive function things, because what is expected of child will be depending on what the child has, the severity the child has. Because somebody who's just mild, just diplegic, cognitively preserved, you have much more expectations in the cognitive functioning and the executive functioning. But obviously, if a spastic quadriplegic is there, whose activities of daily living is completely dependent, that's something different. So it will be, expectations would be different depending on the etiology and the severity of damage.
True. I think because there's so many different types of seizures seen in CP, generalization, myoclonic, infantile spasms and all, one has to also keep in mind that they evolve with age, and similar the management also, even the pharmacotherapy also, taking into account the weight of the child, so many other factors that the evolving child actually shows. And even those touch reflex epilepsies, some of those unusual ones. I think you brought out the variety, the spectrum of those, and the factors associated with these, polytherapies and additive side effects of the drugs, which actually is a big problem for people treating the children with seizures. But in addition, there's one thing which I really like that you brought out, that nurturing care framework and the importance of social support and counseling for caregivers. Because I think the parents and families are so distressed in this combination or this double whammy. But I think while it can seem like a double whammy to the caregivers struggling with the primary diagnosis of CP already, epilepsy, I think we should remember, is not an untreatable condition, or at least we can try our best. But one important thing is the change in attitude, which you also brought out, the attitudes and practice attitude is very important. So I think without going about more on this topic, I think because we are, I think, running out of time, I just will say that what you said about being challenging and being defeated, when you made the difference, I remembered a quote by Dr. Brunstom. Brunstom was the founder of Cerebral Palsy Center at St. Louis Children's Hospital, and she has CP herself. And she said, I tell the kids, it is not fair that you have CP, but you also have two choices. You can crawl into a corner until you die, or you can fight back. I think this is a valuable lesson that I would also give to all families who are dealing with this double whammy. And I think it has been such a, busy evening for everybody trying to take in a subject that is so vast that I would just ask Sheffali if there's anything else to add, or I think the conveners of this organizers could actually decide to, in fact, see if this is to be ended now.
We'll end the meeting, madam.
I just saw one question. Sir, one question I saw. Sir, stem cell, no conclusive evidence for stem cell. Right now, there's some guidelines being made. So there's a question on stem cells. The guidelines are being made by the ICMR, in which all the meta-analysis and all have been done. And right now, it is going to come up. But as of now, it is acceptable only in research mode. It is not, there is no conclusive evidence that it is going to benefit. So please do not be swayed by commercial advertisements, and Asha would be, I think Asha can say beyond this, and Mallikarjun sir also say, I think we have to stick on, actually, we should not let ourselves be exploited. We have to understand when there is evidence, then we should go all out. But right now, even in ICMR, what is being now, with after all the meta-analysis and all those things being now seen, revisited the guidelines, and it is still says that the guidelines is going to say that only with the you can take part in trials, in which obviously when you take part in trials, you don't pay for it.
Thank you, madam.
Very well said. Very well said,
Madam.
Sheffali.
In 2014, we have made a protocol for the stem cells, madam, that they can visit our website to know what is the ISCP stand for on stem cells therapy. Madam, thank you very much for sparing your valuable time to educate us on epilepsy management. Despite of your hectic work schedule, I know that today is after 2 days holidays for others, and being a busy work schedule, you have spared your valuable time to teach us. And your enlightening lecture is very, very informative and has greatly enhanced our understanding, madam. I thank you very much, and thank you, Dr. Sunanda, madam. I request Ankita Bansal to say a vote of thanks on behalf of Indian Academy of Cerebral Palsy to all the participants and our distinguished speakers, Sheffali Gulati madam and Dr. Sunanda Kolli madam. Ankita?
Yes, sir. Thank you so much, sir. On behalf of Indian Academy of Cerebral Palsy, I would like to thank Dr. Sheffali ma'am. Ma'am, thank you so much for giving your valuable time and sharing your invaluable knowledge with us on such a beautiful subject. That too so crisply. It was so informative for us. Thank you, ma'am. I would also like to thank Dr. Sunanda Reddy ma'am for giving her valuable insights and concluding this session, moderating it so nicely. And lastly, I would like to thank all our participants for giving their time and joining us for this webinar and attending it so beautifully without creating any hindrances and asking so many questions. And lastly, I would like to thank Dr. Mallikarjun sir and Asha ma'am for organizing this webinar. Thank you, everyone.
Thank you.
Thank you all.
Thank you. Thank you, everyone. Bye-bye.
Bye.
Thank you, madam. Thank you, madam. Thank you.
Thank you. Thank you, sir. Thanks for the opportunity. Thank you.
Bye, Sheffali. Bye, Sunanda.
Bye, Asha.
Bye, everybody.
Thank you,
Thank you.
Shall I end the meeting?